Hello to everyone who's registered for and is now participating in our first webinar from the Adventist Bioethics Consortium. This is Gerald Winslow. I'm sitting here in the Thompson Library of the Center for Christian Bioethics. And with me are three people I'd like to introduce who are going to be presenting. Dr. Grace Wee will be presenting first. And she is the director of our clinical ethics service here at Loma Linda University Health. She's also a pediatric intensivist, and she has a graduate degree in ethics in addition to her medical degree. And also presenting this morning, or if you're in a place where it is afternoon, is Carl Ricketts, our director of chaplain services. I asked him how long he's been at Loma Linda, and he said 1.75 years, which I thought was very precise. He's looking after our chaplains in the hospitals and providing leadership there. And Carl will be presenting in due time. And then I think next up on the program after Grace Wee is Kathy McMillan. Kathy is the director of employee spiritual care. She's an ordained Seventh-day Adventist minister, and she's also a nurse and has spent decades here combining spiritual care with the health care that we provide here at Loma Linda. And I am the director of the Center for Christian Bioethics here at Loma Linda. I want to just say that this is the first in what we hope will be a series from the Adventist Bioethics Consortium. And the way we conceive of this consortium is really a learning collaborative where all teach and all learn. And so we're looking forward to suggestions from those of you who are participating today. In due time, there'll be an opportunity for you to raise questions, and we'll convey those questions to the group here. If you're having any trouble with the sound or anything, you can raise your hand, and we'll see that you'll notice down at the bottom of your screen, or perhaps in some cases at the top, look for a little hand that you can raise. That'll give us a sign that we may be having some troubles with our sound. If you're not succeeding at all, you may want to give our office a call at 909-558-4956. Let me repeat that. 909-558-4956. You'll reach our assistant, and at least we'll know about what the problem is, even if we aren't able to fix it immediately. If you have suggestions for future webinars, we would like to hear those. And if you would like to help produce a webinar from your part of the network, we'd like to know about that too, because the idea is that we will create this learning collaborative in which we all have opportunity to raise questions and also to provide answers that have been helpful to us in the different facilities where we work. So with that introduction, let me add that as far as we know, our speakers today have no disclosures to make. I think we have a slide about that, but none of us makes any money off of this. We don't have any, we might wish we owned stock, but we don't own any stock that relates to anything that we're talking about here today, nor do we have any other conflicts of interest that we've been able to identify. That's the usual disclosure that's made. And with that introduction, I'm going to turn the time over to Dr. Grace Wee. Grace?
Thank you so much. Again, warm welcome to everybody here. Just a little bit about, let me see if I can advance the slide here. Oh, there we go. Here's our disclosure slide. A little bit about our objectives today. Today, we're really going to talk about surrogate decision-making, and my job is to talk about more of the nuts and bolts of surrogate decision-making and the ethical standards of surrogate decision-making. We're going to examine what it means practically, how surrogate decision-making looks at the bedside through the lens of a patient, and then we will then have presentations from other perspectives. Again, I'm a physician and a clinical ethicist, so I do approach it from the perspective of a physician, but I am the first to say that the physician perspective, if just taken from my perspective alone, is wholly inadequate and incomplete. So I'm very grateful for the other perspectives we're able to bring to the table here. Since I'm a physician, again, I always think of everything around patients. So this is a patient. It's based off of a real case. And so this is Mr. S, and he was diagnosed with colon cancer 6 years ago. On initial diagnosis, he had surgery, he had chemotherapy, and he was able to achieve remission. But then a year ago, he was diagnosed with recurrent colon cancer. And unfortunately, at the time of this diagnosis, there was evidence of metastatic disease. He met with several surgeons, he met with the palliative care team, and after meeting with all the various subspecialists, he and his family decided that since he was not a surgical candidate and since there was a poor long-term prognosis, he wanted to really focus on quality of life. He did have a round of chemotherapy, but suffered severe side effects. And so because of that, he decided to forego curative therapy. He decided to enter into a palliative care type of relationship with his providers. And he wanted to focus again on making sure that he was able to spend quality time with his family. He did have a loving and intact family, wife of 42 years, 3 adult children, and 5 grandchildren. As some of you might know, sometimes it's rare to have a family that is agreeable with a patient in the diagnosis, especially a diagnosis to forego curative treatments or chemotherapy. But the family all supported Mr. S's decision. He also had the great fortune of having very good insurance and an established relationship with his primary medical doctor, who also supported his decision. So again, after the discussion with the family, they declined from further chemotherapy. He was transitioned to palliative care, and as part of the advanced care planning, he filled out an advance directive, and in his advance directive, he named his wife as his durable power of attorney. Also on the advance directive, he requested to not prolong his life. Now, for those of you who are unfamiliar with an advance directive, I want to direct you to this website. Again, I don't have any affiliation with this website, but these are resources that can be easily found on the internet. This particular website allows you to download your state's advance directive. Each state may have a slightly different variation in how the advance directive is worded. But if you would like to fill one out or refer patients or people that you know who are interested in filling out an advance directive, this is a great website to go to. You can get to this website from a variety of ways, AARP, caringinfo.org, or the NIH has an advanced healthcare planning directives website. Again, all of the information is on this slide. So Mr. S did fill out an advance directive. This is the California form of the advance directive. And when I mentioned earlier that he made a choice not to prolong life, this is what he made the choice to. And this is the exact wording from the California's advance directive. And it states, I do not want my life to be prolonged if, 1, I have an incurable or irreversible condition that will result in my death within a relatively short time. 2, I become unconscious, and to a reasonable degree of medical certainty, I will not regain consciousness. Or 3, the likely risks and burdens of treatment would outweigh the expected benefits. The other choice would be to choose to prolong life. And again, that is not listed on the slide here, but in the advanced directive form, there is a choice between not to prolong life or to prolong life. So going back to Mr. S, he filled out an advanced directive. He named his wife as a durable power of attorney, and he requested not to prolong life. And then in conjunction with his primary medical doctor, he filled out what's called a POLST form, and POLST, P-O-L-S-T, stands for Physician Order for Life-Sustaining Treatment. By the way, in some states, POLST, the P in POLST stands for Provider Order for Life-Sustaining Treatment. But either way, what this is, it is an order, it's an actual provider or physician order that helps emergency medical responders to understand what your wishes are for end-of-life care. And so Mr. S filled out a POLST, and he requested do not attempt resuscitation. He requested limited additional intervention and no artificial nutrition and hydration. For those of you who are not familiar with the POLST form, I want to direct you to a couple of websites. I apologize for the graphic on top of each other, but you can go to post.org in order to find out more information for about the POST form. The POST form, again, is statewide, and so I'm going to show you a picture of the California's POST form. And just as a plug, again, a freebie for the National Healthcare Decisions Day, but it's April 16, and this is when many physicians will actually push for their patients to participate in advanced care planning. So again, this is the POST form. There are 4 sections to the POST form. The first one is for the patient to choose whether they would like to receive CPR if they are found to be pulseless. The second box, B, is whether they want full treatment, selective treatment, or comfort-focused treatment. Section C talks about artificially administered nutrition, and Section D is the information that is listed on there, and it states whether the patient has an advance directive and whether they have a healthcare agent. It also requires a signature of the physician, the nurse practitioner, or the physician assistant. And it also requires a signature of the patient or the legally recognized decision maker. So let's go back to Mr. S. Again, he did advanced care planning. He wants to focus on quality of life. And he still is actually enjoying quite a good quality of life. He has good functional status. But all of a sudden, he starts to experience severe abdominal pain, distension, nausea, and emesis. His family brings him to the ED, and they diagnose him with complete large bowel obstruction from a tumor. They do get a surgeon to consult, and the surgeon says, well, we can decompress the bowel and place a colostomy. We can bypass the obstruction, but you're going to have to go through surgery in order to receive this therapy. There are a couple of other ways that we can do it, but we think the best way to get you the outcome that would be best for you is to go through surgery. At this point, Mr. S has a confused mental status. He has an acute illness, which can often decrease mental acuity in patients. He's also been given opioid pain medications for relief of pain, and he's really not able to go through the process of making this decision of whether to consent for surgery. Mr. S's wife, Mrs. S, and a daughter are at the bedside, and so the physicians asked Mrs. S to make the decision regarding whether to perform the surgical intervention. So these are the clinical and ethical considerations in this case. When should Mrs. S start making decisions on behalf of Mr. S? She is the named DPOA. Should Mrs. S decide to pursue surgery when Mr. S's code status is listed as DNAR? If Mr. S has started on IV fluids, is this considered artificial nutrition and hydration? If Mrs. S decides to pursue surgery in IV fluids, can a clinician decline to provide this type of medical care because it appears, or it may appear, to contradict Mr. S's stated wishes on the POST and advance directive? And if Mrs. S decides to pursue surgery, is she fulfilling her duty as Mr. S's surrogate, or is she making decisions based on her own wishes for her husband? These were the questions that were brought up and posed to the clinical ethicist who they called to help sort out the decision in this case. It should be noted that a couple of the options a couple of the questions that were not specifically discussed was if they decided to not pursue aggressive surgery, not aggressive, but if they decided not to pursue surgical decompression, it was thought that not pursuing surgical intervention may more be in keeping with Mr. S's wishes. So that part of the discussion was not as fully explored. So let's step back a little bit from Mr. S's case, and let's talk about what surrogate decision-making is, and really what are the standards of surrogate decision-making. There are 3 standards of surrogate decision-making. The first standard is stated wishes. The second standard is a substituted judgment, and the third standard is called the best interest standard. So stated wishes, this is where the patient can make their own wishes, whether written wishes or oral statements, in which they direct their surrogate decision maker or their agent to make a decision for them if a certain situation comes to pass. However, not everybody can actually anticipate what may come to pass. There are so many variables that can occur that even though a patient may have given explicit wishes for scenario A, scenario B happens. What do you do then? This is where we would go to substituted judgment. And we would ask the surrogate decision maker to make a decision that the patient would have made based on their knowledge of the patient's goals and values. So this is where we would ask the agent to put themselves in the shoes of the surrogate. And we would ask the agent, knowing what you know about the patient, knowing the situation, knowing the patient's goals and values, what do you think the patient would have done? Or what kind of decision would the patient have made? The last standard is called the best interest standard. And this is when you really don't have direct knowledge of what the patient would have wanted. And so then we are going to decide for the patient based on commonly held societal values. Or we're going to make a recommendation for the patient based on what we feel is in their best interest, taking into account information that's specific to the situation. So again, the stated wishes standard, this is direct information from the patient. It can be formal or informal. It can be written or oral. However, I will say that if it is an oral statement, the courts may give legal documents more weight than oral statements. Typically at the bedside, we don't want to invoke the courts or legal proceedings into the specific patient interaction, but that's just an aside. This is this is something that is very important, and this is probably one aspect that I do want to emphasize. If you have a couple of things that you take away from this webinar, this is one of them. All advance directives, all formal statements or informal statements, stated wishes, so on and so forth, everything that's stated from the patient will need some degree of interpretation to ensure that the current situation fulfills the intent of the patient's stated wishes. And the degree of interpretation will need to be done by the surrogate decision maker or the agent. And we say that all advance directives need some degree of interpretation because it is impossible for one person to anticipate every single scenario that could come up. What are some problems, though, with the stated wishes standards? Well, some patients may not be as informed as they should be. Sometimes patients change their mind and they forget to tell their family or friends, or they even forget to write it down. Sometimes the wording of the advance directive is vague, and it requires not just a little interpretation, but a great deal of interpretation. So if you will allow me just a little bit, I'm going to go back in these slides, and we're going to go back really quickly to this area of the advanced care directive form that Mr. S filled out. And it says, I do not want my life prolonged if I have, for example, an incurable or reversible condition. Now, I would love to say that physicians have great skill in prognosticating the future, but we do not. And so when you talk about an incurable or irreversible condition, these are quite vague words that need to be interpreted by both the clinical team and also the surrogate decision maker. So excuse me while I go back and click back to this slide here. So we talked about patients not being informed, changing their mind, vague wording of the advance directive. Sometimes the stated request may appear to conflict with the patient's best interest. So a patient may have a very strongly stated request, I do not want X. But what if you do X, that will result in an outcome that will actually benefit the patient. The other problem is that not very many people have advance directive or POLSTs. So again, these are some problems with the stated wishes standards. It's better to have something rather than nothing. The most reliable advance directive or pulsed or stated wishes are consistent over time. And most importantly, they're consistent with the patient's lived and stated values. So how do we avoid problems with the stated wishes standard? Well, first, we advise patients and their families to talk about the treatment first, the goals of the treatment, and then about a specific intervention. So oftentimes, patients may say, I do not ever want to have this kind of technology. But what if this technology is what is required in order to improve your overall condition? So technology is value neutral, but the goals of treatment are very specific to the patient. We encourage patients to speak with their physicians and their providers, talk about the most likely scenarios, have serial conversations over time. And this is going to be important not only with your physician, but also with your family and the person you've assigned to be your surrogate decision maker. And we encourage patients and family members to document these conversations with goals or written documentation of goals, values, and also wishes. Let's talk briefly about the substituted judgment standard. This is indirect information. So when you make a decision based on the substituted judgment standard, you are extrapolating from the current knowledge that you have about the patient. There are problems to this, though. There's little to enforce consistency. It may not accurately reflect the patient's wishes. This is actually really hard to do. So if you say have a patient who did not leave an advance directive, but you have a loving and devoted family member who knows the patient very well, how do you guide them to be able to make decisions on behalf of the patient? This is a fantastic article that will be linked to on the website. It's called Substituted Interest and Best Judgments. It's published in JAMA in 2010. And it gives these steps of what clinicians can do in order to guide patient families toward this process of making decisions on behalf of their loved ones. So here are some ways to avoid the problems in the substituted judgment standard. First is really to get to know the patient. If you understand what the patient's goals and values are, it will make the decisions easier. We always recommend clinicians to keep the focus on the patient and don't put the focus on the surrogate. I have often heard clinicians say something similar to, you don't want your loved one to suffer, do you? And it really puts the onus on the surrogate when it takes focus away from the patient, and the patient should be the center of this discussion. Other ways to avoid problems: establish common ground with the surrogate and make a medical recommendation for treatment. And a lot of these recommendations, again, will be based off of the Solmese article, which again will be linked to the website. The best judgment standard. So the best judgment standard is based on medical judgment and commonly held societal values, but it's it's concerning that it can be subject to clinician bias. And also for clinicians, it's uncomfortable to be the decider. So how do we avoid problems with the best judgment standard? First, it is absolutely important to obtain a clear medical picture, to elicit multiple viewpoints, to address possible biases that may be present on behalf of the deciders. And often, a trial of therapy allows for time to clarify the situation when it is unclear what the best decision is. Just a brief word on who can be a surrogate. Well, you must be willing to serve, you have to be able to interact with the medical team, and you have to have direct knowledge of the patient's goals, values, and wishes. If you don't have direct knowledge of what the patient would have wanted, at least you need to know about the patient. So we usually say that the person who can be a surrogate is the person who knows the patient the best and loves them the most. And just a brief note about the legal qualification. So agent is the term we usually use if it's named in a legal document. A surrogate is a person who is the decision maker for the patient and who's presumed to be in a position to serve by nature of the relationship to the patient. If there is a hierarchy for surrogate decision-making, that is determined by state law. So let's go back to Mr. S. Is Mrs. S qualified? Yes. She was named as his agent, so that's a legal qualification. She's his wife of 42 years. She knows him very well. And the standards that she should be using, stated wishes. She and Mr. S did have several conversations about what he would want. And also, she is probably going to use substituted judgment, meaning Mr. S may not have foreseen that he would have a bowel obstruction and need surgery, which would require intubation. So how are we going to guide Mrs. S through this? Well, we want to start with the goals and values. Then we discuss prognosis and reversibility. And really, how do we get Mr. S to his treatment goal given the medical reality? And finally, is it consistent with his previously stated wishes? So what were his goals and values? He wanted quality of life, and he defined that by being able to be with family and friends, being able to live at home, recognize and interact with his loved ones, and to live without the aid of technology. So he did not want long-term artificial nutrition hydration. And again, the most important of all of this was time with family and friends. Now we talk about prognosis and reversibility. So per the surgeons, because he had good pre-surgical functional status, they expect that he will have good post-surgical functional status. Even though he will need to be intubated for surgical intervention, they think that he will likely can get extubated. He will probably need an NG tube until the bowel function returns. He may need TPN, but the expectation is that he will regain bowel function and be able to eat because the colostomy will actually bypass the obstruction that he has currently. He will need to live with a colostomy bag until his death. And so his likely acceptable functional status post-op will be not dependent on the ventilator. They don't think he will need tube feeds. So what is the best way to get him to his his treatment goal? Well, this is where we discuss with the family whether Mr. S would have been willing to accept short-term invasive technology for long-term gain if he thought that an acceptable quality of life included a colostomy bag. Most people would not consider colostomy bag as being dependent on invasive technology. But there are some people who would think that a colostomy bag would not constitute acceptable quality of life. One way to do this is also to discuss the worst case scenario. What happens if there's complications in the OR or in the ICU? And then to discuss with the family other treatment options. And again, are these consistent with his previously stated wishes? So remember when we talked about how all advanced directive and post forms need interpretation, this is definitely an instance where an advanced directive and a post form, which states do not attempt resuscitation, limited additional treatment, and no artificial nutrition hydration, this requires interpretation by the family. And we really encourage patients and families to focus on the treatment goals, not the individual technology. If there is absolute resistance to a certain technology, and that becomes the primary treatment goal, patients and families should recognize that this may be at the expense of other goals. So with a summary of points here, we talked about the standards of surrogate decision-making. But also, I'm hoping that this presentation helps people realize that surrogate decision-making is extraordinarily hard, because all wishes need some degree of interpretation. And so how we can help families is to get to know the patient and to focus on the patient's goals and values to help guide medical treatment. If we focus it on the treatment and the patient and not the individual technology, then I'm hopeful that we will be able to find a path of treatment that will be best for the patient. Very briefly, these are the topics that we didn't address. There's a bit of them. This is a very narrowly focused talk specifically about surrogate decision-making itself. But one thing is that we're not addressing right now is what happens if there's conflict between either family members or the clinical team and the patient's family. That actually can be a webinar all in itself. But with that, I want to turn the time over to Kathy.
Thank you, Grace. And I appreciate the opportunity to be involved in this. My background is in oncology nursing when I was doing clinical work. And I think that nursing professionals have an opportunity to be very involved in surrogate decision-making and working with the physician and the rest of the multidisciplinary team as decisions are made. There was a systematic review of literature that was done by Judith Adams at Duke that took a look at many, many studies that have been done and kind of categorized the ways that nurses can be involved into 3 areas: information broker, supporter, and advocate. And we're just going to run through those real briefly as we talk now. As an information broker, a nurse is actually giving information to both physicians and to the family members. I know that when I was doing clinical nursing, many times the physicians would count on the nursing staff to give them information as they came in the morning, not just about the patient's clinical status, but information about the family. So, what is the family's emotional state? Are they resistant to what's being suggested, or are they having hesitation about what's going on? What are the expressed wishes of the patient and the family members? I remember one situation where a family had found out that the patient's sister was going to be flying in the next day, and this was a huge desire on their part, was to keep her alert enough until the family arrived. In terms of giving information to the family members, nurses can be very involved in that as well. Explaining the equipment and the clinical status of the patient. Oftentimes, helping to restate what has been said into lay language. Physicians often do that, but sometimes patients just don't hear. They can't hear because of information overload or because of their emotional state, and they don't want to hear bad news. So sometimes a nurse is really important in being able to restate what was already told to them, as well as education. And lastly, in terms of information brokerage, is the mediation. Not necessarily mediation in the way we think of helping to mediate disagreements, but just bringing people to the conversation together and involving the other disciplines in that care. Next, a nurse is often involved as the supporter. In order to be a good supporter, a nurse must build trust. And so that means introducing the family and the patient to other staff members, allowing the family to participate in care. I remember one woman with ovarian cancer who was very near the end of her life, and it was time to give her a bed bath, and the daughters were just kind of standing in the side of the room and trying to, looking very awkward, but trying to figure out what to do. And I invited them to help me with the patient's bath, and they were so appreciative of being involved in that. Nurses can find out what's important to the family. I think the whole healthcare team needs to be involved in that and trying to elicit that information. Is it more important to the patient and to the family that the patient be free of pain or have clear mental status? Helping to maintain hope is something that's so important. I think that all of our roles in holding hope for patients is vital. And for family members, it can be so discouraging for them. But to be able to name some of the strengths that you have seen in them. So for instance, to be able to say to a family member who's feeling very discouraged, to say, one of the things that I've noticed as you have been caring for your husband is the incredible amount of strength that you have. And even though you're facing very difficult situation, you have been able to maintain a real positivity that has been beneficial to your husband. And that kind of thing, when it's named by a healthcare provider, can really add strength to the patient and their family. And lastly, helping to prepare them for bad news. If a nurse comes in and has already seen the results of a scan that's been done, and the family's talking about how difficult it is to wait, the nurse might say something like, "It's so hard to wait, isn't it?" And then he or she might add, "And then sometimes it's hard to hear the news too." So you can kind of be involved in that preparation state without saying what's coming. As a supporter, it's very important for the nursing staff as well as other team members to show empathy, trying to figure out how we can convey understanding to the family and how they are seeing that situation. Acknowledging their feelings. I always like to say that our goal is that the patient and the family comes to the conclusion that we really get it, that we understand what they're going through, without us ever saying, "Oh, I understand," because there's nothing more frustrating than that as a patient or a family member. The third and final role of nursing and surrogate decision-making at the end of life is an advocate, which is one of the great roles that nurses see for themselves, but advocating for the patient to the physicians, questioning sometimes the plan of care. Are you sure you want to do another test? The patient and the families was conveying a little bit of hesitation about that. Sometimes it might be planting a seed. If you have a physician who is very, very much in the curative mode, to be able to ask a question and be able to say, at what point do you anticipate that you might quit, pushing so hard for a cure? And sometimes timing discussions so that the best physician will be present, particularly in a teaching hospital where you have different people who are on call at different times. A nurse may feel like there is a physician that will be best suited to a conversation with the family. And then advocating for the patient to the family. So helping the family, as Dr. Wee was talking about, to clarify the goals of care. What was it that patient had stated and written about that they wanted if they are no longer able to be expressing their wishes? Sometimes explaining the implications of the decisions that they will make. Well, if you make this choice, then we anticipate that this may happen. And coaching families to make those decisions that are consistent with the patient's goals, and helping them to accept the inevitability of death, to be able to say things like, what is it that you have understood from what the doctors have said? And then maybe to be able to just comment, he seems very sick. His body seems so tired. Those kinds of things can help to prepare the family. So there are those three ways that nurses can be involved as part of the broader healthcare team. I'll turn it now over to Carl.
Thank you so much, Kathy, and thank you so much, Grace. And it's a privilege to be here and present with each of you, and in the time that is ours to share. In looking at some of the standards and pitfalls in surrogate decision making, I want to come from a religion and spirituality point of view at end of life situations. Individuals, patients who are sick, they have a deep reliance on religion and spirituality to cope with their diagnosis. This is coming from the Journal of Palliative Medicine. And first, I want each of us to understand that these patients who are in our healthcare institutions, they have a deep connection with their faith community. And also it suggests a relationship with their clergy. So as healthcare providers, we want to look at the fact that our care recipients have a deep relationship with the clergy of our community. And when you look at that connection, you notice that clergy are uniquely positioned to help patients consider medical decisions at or near end of life within a religion and spirituality framework. Here's the challenge. The challenge is that the clergy's knowledge of end of life care and end of life situations, it is poor. With all due respect, our ministers don't have as much exposure to what is happening in the hospital. And so as we have, as some ministers actually have gone through this study that was taken in the Journal of Palliative Medicine, it was determined that ministers in the community, they are uncertain and passive in their approach to counseling congregants about decision making. How does that impact the patient? It impacts the patient because patients are more prone to go for aggressive care, aggressive treatments, kind of diminishing comfort care, looking to sustain life. And the article also demonstrated that while this may not necessarily be the belief of ministers for end-of-life care, their passive approach to counseling their congregants, it allows many of the families and the patients who are in our hospitals to seek to prolong life. Why? Many times that is connected to their faith. Many times they're taught about life. And when you're taught about life, you want to sustain life. And you may not necessarily see the value in accepting death. And so from this presentation, from this article, a theological framework for end-of-life decision-making was actually produced. Many of the pastors wrestle with the reality. They preach life, teach life. And so there's the seeking part of life where you might have miraculous healing or you might have redemptive suffering. Miraculous healing could be described if we are not praying for the impossible, sometimes we have no faith. And also looking at the redemptive suffering, we do think that suffering is a part of God's way of testing me, but at the same time, we don't invite or embrace painful procedures. These are just some quotes from clergy. And then looking on the flip side, the accept side, looking at where death comes, concerning God's will. First thing, a congregant told the doctor, well, I don't want you to do CPR. If God calls me, it means it is my time to go. And then looking at relief from suffering, I don't think God calls us perhaps to suffer in that kind of way. One, in seeking life is leading itself to life-prolonging treatment, and the other one, acceptance, more to comfort-focused treatment. Ministers are wrestling with the fact that there's an access point. There's a point where ministers need to be able to convey and counsel parishioners, patients, on this balance between seeking and accepting. And this is where we're finding out that much work is still to be done in our communities. Some of the factors that also hit this are age, family, and community responsibility. Clergy cited age and family or community responsibility as factors that should impact decision-making. In contrast to the elderly, young people were thought to have more responsibility to pursue therapies aimed at prolonging life. Prognosis and treatment burden, faith in God's ultimate power to heal, and examples of patients outliving the prognosis given by their physicians led several clergy to feel that decisions to pursue invasive treatment may be justified by prognostic uncertainty. And free will is a major one. Even as one minister declared, you hear, you learn, and based on your convictions, you decide. Based on the convictions of the scriptures, his word, your understanding, You decide. Again, kind of putting it more so in the realm of the patient and also the surrogates. And so this is what we're looking at. Patient preferences for intensive end-of-life care. We can see that it does come out of this passive approach, which many ministers articulated that they wish they were not so passive in this. And so you see that patients are optimistic. They have optimistic prognostic perceptions, more intensive cancer care, and less frequent and shorter hospice use. And so seeking life and accepting death, this access point is important. This is where the chaplain can come in. And so when we think of how a chaplain can be the bridge, a chaplain actually can come in and their spiritual care combined with knowledge of end-of-life care to help the family and the surrogates at this access point of seeking and accepting, helping them navigate where we are in this moment right now. The chaplain also has the ability to connect families with healthcare providers through the avenue of religion and spirituality. The chaplain can also, while they provide spiritual care for the families, for the surrogate, they can also provide spiritual care for the care providers. Many times in futility disputes, care providers are frustrated or can become frustrated because they have time that is being put towards care of this individual while they could have time going towards another individual. And so the chaplain has the opportunity to serve as a bridge. Mrs. M, this is actually a situation that I experienced. I won't name the institution, but Mrs. M has experienced brain death, and the family has been approached by the organ donation procurement team. The family does not understand brain death and have many questions regarding the theological implications, specifically eschatologically, yes, I got it right, for Mrs. M, if her organs are donated. Futility dispute, the dispute is the patient has been pronounced brain dead. The family still thinks that care should be given. They don't understand brain death. Eschatology, we're talking about end of life. The patient's family, they have a view as to how this treatment and care, especially organ donation, will impact their loved one in their faith tradition at the second coming of Jesus Christ. Faith is important. This family was coming from a Pentecostal tradition and had heavy reliance on their minister. And then we wanted to get to a medical decision that was based off of being informed medically and also being informed theologically. And so what the chaplain was doing was creating a conference. What I did, create a conference for the medical team to come and actually speak and explain medically what was going on with their loved one. While the patient saw the respirator causing the patient's lungs to be functioning, they did not understand the process of brain death. And then also brought in the clergy, had a conference with the clergy for the clergy to understand what end of life situations were going on at the moment. And through the collaboration, the family became educated in understanding brain death. And they also, and this was not the goal, but the family also ended up in performing organ donation in this situation. I would say religion and spirituality takeaway, the surrogate care provider relationship, it is a large one. Collaborative relationship versus unilateral decision-making is to be preferred. We don't want the family to just make their own decision. That will prolong the situation. And we don't want medical team making their own decision. It is important, though it's painstaking and it takes time for everyone to come together. Chaplains can be very instrumental in bringing all of these entities together because the chaplain understands the faith dynamics. They also understand end-of-life issues. Patients who have strong religious beliefs underlying their rationale will benefit from acknowledgement of their beliefs. And so if we can acknowledge the spiritual, the religious beliefs of our patients, I believe that we will have positive outcomes in our surrogate decision making.
Okay, thank you. I'm going to just name our speakers again. Dr. Grace Wee, a pediatric intensivist and head of our chaplains, or our clinical ethics service. Kathy McMillan spoke. She's a nurse and administrator and an ordained minister. And then our head chaplain, Carl Ricketts. There is opportunity for a few minutes here for you to submit questions. I think you'll see that opportunity on your screen, although I can't see what you're seeing on your screen. But if you explore there a bit, you may be able to submit a question by typing it. And we'll try to get to as many of those as we can in a very few minutes here. Let me start with a question here that has often occurred to me. We have a decision maker who's duly named, and there's no dispute about the one who's been named, but they don't seem capable of making a decision that we would call reasonable or intelligent. We're not even sure that they're really following the patient's wishes. What do you do with what I've sometimes thought of as an incompetent decision maker who's been named as the surrogate? Now, incompetent, I understand, is kind of a technical term of art that means that they're legally not able, but that's not really what I'm talking about. It's just that all the signals you have is this person's not able to serve the function. I'm going to start with you, Dr. Wee, since you led off here. Solve that problem for us.
That's a very difficult situation. So surrogate decision makers or agents are held to the same standards of decision making that a patient would be in demonstrating the ability to make the decision. So, for example, they have to be able to understand the situation, to appreciate what are the different treatment options, to be able to reason their way as to why decision A is going to be the best for the patient, especially if the patient has stated wishes. And they also have to be able to communicate with the medical team in a reasonable manner. So if they're unable to perform the duties of the surrogate, the first step, what we usually do is to try to understand the difficulties that the surrogate may be having in fulfilling their duties. Sometimes it's emotionally very difficult, in which we would want to make sure that we're providing enough emotional support for the surrogate. Sometimes it is, like, for example, one case that brings to mind, the surrogate was having to expend a large amount of her own personal resources in order to be at the bedside and to come to the hospital. And so at these times, the hospital can actually help with transportation costs, for example, or helping the surrogate to be able to be accessible to the patient and also to the medical team. But in very difficult situations, unfortunately, it may come down to the point where that the named surrogate is actually not the best person to make these decisions. And in these unfortunate circumstances, it would need to go to court. So legal counsel should be sought. Legal assistance should be sought. And during this process, when legal counsel is being sought, the medical team should, as much as possible, try to honor the wishes of the patient and to make sure that the best decisions, and this would be a best interest sort of decision for the patient, are being made on behalf. But very difficult situation.
And those of you who are participating now, at the bottom of your screen, you will see a little button that says, or you should see a little button that says Q&A. And when you hit that button, you should get a dialog box that will allow you to submit a question if you would like to do that. And at the end of our session, which will be very soon, we'll also give you some other ideas about how we can continue the discussion. What happens when, I'm going to go back to a statement that you made, Dr. Wee, that these advanced directives are always subject to interpretation. Somebody says, I want everything. Well, what is everything? Presumably that's every medically sensible thing, but then you can have forgive me for observing it, but you can even have an argument among caregivers, healthcare professionals, as to what everything is, as to what's useful, what's even scientifically evidence-based. So now you have a couple of adult children show up, and they're interpreting mom's statement about I want everything or I don't want everything, and they seriously disagree. That's not what mom said. That is what mom said. What do you do when you have conflicting and seemingly similarly authorized surrogates? I mean, I realize that some states have a pecking order, a hierarchy of decision makers. Some states don't. I think California doesn't actually have a stipulated pecking order. So what do you have? What happens? And I'll invite any of the three of you to join in there. We may need a chaplain before this is over.
I would have to say in family conflict, this is where we really rely on nursing staff and chaplains, social workers, and other staff. At least I find, I mean, I cannot alone figure out the family dynamics. We always try to make sure that the focus is on the patient and not to put the different family members under the microscope to see who really is the best decision maker. You know, I think that takes away the focus from the patient. And again, let's talk a little bit more about what mom's goals and values are. And again, you know, Kathy, I've found the nursing staff and social work and chaplaincy to be extraordinarily helpful in these sorts of situations.
So here's a question from one of our participants. Can the Bioethics Committee or the Hospital Institutional Ethics Committee become the surrogate, or maybe name a surrogate or recommend a surrogate? What's the role of the committee? And we realize, of course, these committees may vary considerably from jurisdiction to jurisdiction and size of the institution and so forth. But what would your comment be about what is the role of an ethics committee in resolving any issues about a surrogate decision maker?
So the first one is to really understand whether there is somebody who's able to serve as a surrogate decision maker. If the patient doesn't actually have anybody who can make decisions for them, we call that an unrepresented patient. That's kind of a whole topic all in itself. But say there are equally interested parties who want to serve as a surrogate decision maker. Can the Bioethics Committee pick and choose? Well, we would recommend that the person who makes the decision is the person who knows the patient the most and loves the patient the best. Now, this may be, again, debatable. I loved him more. No, I do, you know. And again, putting the surrogates under the microscope isn't really the optimal path here. It's best to, again, put the focus back on the patient and find out a way with the help of our staff to perhaps work collaboratively.
Yeah, I just wanted to chime in. Many times I've seen this situation where you have surrogates, family members, and someone may actually be listed, but if you can foster collaborative effort in the care of the patient, many times you'll find the families, they are in harmony, they're in agreement, and no one is actually trying to pull up themselves as the one who needs to make the decision. And many times the one who may even be on paper, I've seen it sometimes, the one who's on paper, they actually defer to another individual. So families sometimes have a way with the help of themselves and also with the help of interdisciplinary healthcare teams of putting it together.
Well, there are so many questions, and we could obviously spend a good part of the rest of the day talking about all this, and maybe we will right here around the table, but we don't have the luxury of that time on the webinar today. Remember, we'll have other webinars. We may come back to this topic in one form or another. Let me also invite you to go to our AdventistBioethics.org website. That's Adventist Bioethics, all one word. It's really two words run together, .org. And there you'll find a lot of resources and also the capacity to contact us if you scroll to the bottom. You can send questions in. There are a lot of resources on the website. Let me make a little advertisement too for our next, which will be the 4th annual Adventist Bioethics Conference, May 6 and 7, Monday and Tuesday, May 6 and 7. We'll be meeting in Roseville, California, near Sacramento, California, and all that information is available on the AdventistBioethics.org website. There you also have the possibility, if you're in a participating organization, to submit questions for consultation. It may be about policies or difficult cases or other issues that have come up at your place. I think that with that, I'm going to need to say thank you To our participants today, Grace Wee, Kathy McMillan, Carl Ricketts, thank you very much. This is Gerald Winslow, and we'll sign off now and hope to be in touch with you later. Goodbye.